let me go ahead and introduce you all. Thank you for joining us today for our session on managing temper tantrums and explosive anger in pediatric primary care. My name is Laura Young. I am the program manager for the CPAN program, the Child Psychiatry Access Network, here at UT Tyler Health Science Center in Tyler, Texas. I'm so excited to have Dr. Elizabeth Lobel here with us today, one of the child psychiatrists from UTMB. And Dr. Lobel was born and raised in New York City for most of her childhood. From a young age, she has been interested in child development and how it can be impacted by developmental disabilities and by trauma within the child's environment. Dr. Lobel attended New York University School of Medicine for medical school, North Shore Zucker Hillside, now Northwell, for her general psychiatry residency training, and Mount Sinai for child and adolescent psychiatry training. She took a year off medical school to live and volunteer in Jerusalem, Israel. After training, she moved to San Jose, California, and worked in the community child mental health and then private practice. She moved to Fort Bend, Texas in the summer of 2014 and has been working at UTMB since 2014 as well, in spite of moving again in the summer of 2019 to the Tampa Bay area in Florida. So we're really excited to have all of you join us today and to have Dr. Lobel here to share with us on a really important topic, managing temper tantrums and explosive anger in pediatric primary care. So Dr. Lobel, I'll hand it over to you, and I'm going to take myself off camera and off mic.
Hi, so I am Dr. Lobel again, and I am talking today about managing temper tantrums and explosive anger in the pediatric primary care. Sorry. There we go. Where I press. So I don't believe I have any conflicts of interest. I work for UTMB, like she said, and I'm a child psychiatrist. The goals, objectives today are to understand why our kids are having temper tantrums and anger outbursts, to know how to advise the parents of our patients with temper tantrums and anger outbursts, to develop awareness of resources that may help our patients with temper tantrum and anger outbursts. And while it's not first line by any means, to find options for medication for treating our patients with temper tantrums and anger outbursts. Because we do sometimes need to be aware of that, and it can be hard to get them in with the child psychiatrist. So, got to define the problem, support the parent to support the child, consider behavioral tools and techniques for parents, and note on schools, the role of the primary care provider, and resources, including ultimately possible medications. So children and us adults often express ourselves behaviorally when there's no language to explain how one's feeling, thoughts, or needs. When a parent or the caregivers learn to listen or kind of pay attention, observe and understand the difficult behavior, they can develop more effective ways to encourage discipline, appropriate behavior skills, and positive coping skills. By listing and predicting, like thinking ahead of time, what could be a difficult behavior that can help to avoid those behaviors, redirect before it gets too bad, or distract the child, in order to prepare ahead of time so the parent can decrease the severity and frequency of like the meltdown or tantrum. So you don't want to get rid of all tantrums. It's part of growing. You can't always prevent them, and you shouldn't, but it can be helpful because there are going to be situations where it could get out of control or become too much of a problem for the parent to handle. And then you want to try to think ahead and prepare, or the parent does. So this came out much smaller than I meant it to. Well, we have to consider what could be the reasons. Doesn't seem to come up here either. Okay. We're all allowed to be angry sometimes, so it could be age appropriate, situation appropriate, developmentally appropriate. I mean, so sometimes a parent is like, they're, having a tantrum, but it's really just like a normal, what wouldn't expect to be a normal reaction at that age to that kind of situation. Discomfort, physical discomfort like hunger, pain, constipation happens all the time on the elderly geriatric unit. Can be causes of like a tantrum. And obviously in kids, you'll have that and they definitely cannot, they might not be able to explain it. They don't have the language. Sensory averse could be from autism, but could be from other things too, that could be bothered by a sound in the environment, the flickering of I can't think of the type of lights, but the lights up above. It's, certain thing that's on them is touching them. Developmental delay, it's going to get in the way of them expressing themselves. Intellectual, language, autism, that problem lasts. So that way they might have a temper tantrum at an older age or more intense or both expected, partly because they're unable to communicate their distress and partly because it might not be what a typical kid that age would be distressed over. Then there's disruptive impulse control and conduct disorders, which include intermittent explosive disorder, oppositional defiant disorder, conduct disorder, maybe conduct disorder. Mood disorders like disruptive mood regulation disorder, it's like an anger and management issues. But a kid who's depressed can come up as irritable. A kid who's manic certainly also can look irritable. And so that can come up essentially as a temper tantrum. A lot of trauma-related PTSD situations can lead to tantrums that don't seem to make any sense. They're reacting in a way that maybe would have kind of helped them in the actual trauma, but now the trauma is over or that's not happening right in front of them, and it becomes a problematic reaction now. Or it could be just a trigger, almost like what they wish they had done at the time they weren't able to do. Severe anxiety I've seen lead to like tantrum type behavior, anger, outbursts. Because they get a panic attack, they get phobic and have a panic attack. I had a dad tell me, oh, this kid can't really be socially anxious because the reaction she's having is she's a teenager, essentially having a temper tantrum, and that just gets more attention. But essentially what would happen, it would push her to the point of such severe anxiety that she just lost control.
You're gonna leave them in the dishwasher while you washed your head?
Yeah. What? Oh, I think someone was unmuted. Don't think it was about me. Okay. Anyway, psychotic disorders are pretty rare for the younger kids. Usually I find it's more anxiety or trauma that's happening when someone seems to be having hallucinations or something. Occasionally they are actually having hallucinations or delusions. And addiction can be part of it, so they can be from the substance. It could be like that they're withdrawing, so we're looking for. And it could be from the threat to remove, to prevent them from getting access to a substance that's been very helpful for them, or to a situation like some people get addicted to gambling, even teens, or the removal of screens. While that's not officially diagnosis in the DSM, the ICD, I do believe, has accepted that as a diagnosis in terms of like this addiction to screens. And there has been research that shows that there's dopamine release, and there's this similar process to the response in terms of the addiction, so to speak, to the screens as there is with an addiction to like a substance. Move forward for a second. Okay, so understanding causes of challenging or disruptive behavior, that's one place to start. Children with challenging or disruptive behavior might not be able to express what's bothering them with their words and then have the words. They might be acting out things that are happening in their family in response to things happening in their family, based on things happening in their family. Maybe there's environmental social risk factors that make them more likely to have these problems. Temperament, mental health conditions, development. there might be, and often they're ashamed or feel guilty in the context of this behavior, and that makes it hard too because they're doing this behavior, it's getting all this attention, and they might be really embarrassed but have trouble stopping. The parents and the caregivers, guardians of these children, are often doing the best they can. They're often doing the way they learned from their parents, or simply doing what's expected within their own culture, religion. They may be struggling with their own problems, mental health, developmental health, physical health. They might not know enough about child's developmental needs, or that the child has any particular needs. And their expectations may not be accurate and might not be good for the developmental level of their child. They might feel overwhelmed, unprepared, afraid, ashamed, guilty. People judge, people react, and us humans, us parents, you get embarrassed too. And they might not have the community support they need, especially with a kid who's very difficult and might pull away, even if they did have support to begin with. It's important to validate that these types of children are difficult even for the most excellent parents. And even the most excellent parents are going to have to modify their behaviors. It's not that the parent is wrong or bad. It's that you have to adjust how you're treating this kid, maybe, depending on the situation is. It's important for us as physicians to show empathy to the parents who are struggling, so that to help them out, to help them feel better. These behavioral problems can be related to, let's see, sorry, just realized what's going on. Oh, never mind, I thought I saw the wrong one, but these kids could be using some of these behavioral issues that we see as temper tantrums or explosions, meltdowns. They can be using them to self-soothe. So this is something they could have learned early on in life. Language delays. If they're unable to self-regulate, then they get frustrated, and then this could be how they're calming themselves down, or how they're just dealing with the frustration. Kids who are having language delays, they might have receptive language delay, let's say. So this is for kids who have like language delays in particular, some kind of communication delays. Kids with receptive or expressive language delays may use this to understand others. So they can have problems early in life and due to the delays. And if you don't understand what other people around you need as the kid could be getting really frustrated. And as a result, be just acting out, yelling, that kind of thing. And so this is important when you're, for example, considering language. That might be the issue here. Maybe they're not acting out because they're angry, or that they're angry over nothing. It's because they don't understand. They're not receiving the message to understand what they're supposed to be doing. Expressive language delays are an issue for when they're trying to communicate. If they're not able to communicate, they need to be able to get people to understand in some way. A little more in the receptive language. If the kid doesn't understand what's going on, they're going to be frustrated. They might not agree, especially when they're very little, about what's safe, for example, or what they should be allowed to do. And that can lead to the frustration, temper tantrums. And also not understanding can lead to the kid being scared, like, what is going on here? Anxious, because they don't know what's happening. So, back to the expressive language. Once you have expressive language, you can assert yourself a little bit better. But if you have problems early in life, and because of my early language delays, that's going to cause trouble with communication and with expressing yourself properly. And it's also hard, even if you don't have a language delay, but you are an immigrant and you don't speak the same language as everybody else around you. That can be a problem at school with the teachers, and that can be a problem even with their parents. Like if a kid is adopted and new to the country and to the language and the culture, and it's can be very confusing and hard for them. So how can pediatricians help? It is important to assess and address. And so assess, we consider when interviewing a child and parent separately and maybe modifying how we're interviewing the child, of course, based on their developmental level. Review any screens, any histories, any administer any behavioral health screeners. Try to figure out why is the kid doing this? And don't you don't usually ask it directly, like why did you do this? Because like that on the defensive to see like what are you trying to do, or what leads to this behavior, what do they get out of this behavior from the parent, that sort of thing. And work with the parents to track and try to figure out what the function is. Address by listening, empathizing, validating. Affirm that parent is asking for help, coach, and give some positive parenting, and give support, verbal, written, tell them where to look online. Figure out whether to refer. Do they need to go to a psychiatrist or developmental pediatrician or a neurologist for medication? Do we need parent training? Used to be called parent management training. Parent training is known to be very helpful, especially for like the ones that are more just behavioral and not due to a mood or due to language or something. Family therapy, individual, any evaluations you might need, school evaluations, legally the school, so doing that, any accommodations, wraparound services, and then there are evidence-based interventions, classes, that's more like the parent training essentially, parent-child interaction therapy, where they learning how to interact with each other, parent management training or parent training. Defiant teams, positive parenting, all these things. Trauma-focused CBT is something that's known to help for kids with CBT. So then you're also considering, cognition and memory. This is where things apparently got cut off of my slide. I'm not sure how this happened. I don't know how I missed it. Anyway, sorry about that. So consider, are the rules clear and well defined for the kid? Is the kid gonna understand what the rules are? Because if they don't know what's going on or what they're supposed to do, they can't do it. Assume the kid is trying to succeed. What about consequences? Does the child understand what the consequences are going to be? And those well defined. Can the child understand the rules and consequences? Consider their developmental level. Consider if there's anything in the way, like a disability or ADHD. As they get older, they're more physically able to follow the rules and mentally able to do that. They're understanding the rules better. They're flexible, hopefully, maybe not as much with autism, and able to come up with options to deal with their frustration. They get better at improving delayed gratification. By the middle childhood, the typical child can use strategies they've learned to control emotions, can like think about what they're doing and adjust based on what they're thinking. And again, so again, you're thinking about the cognitive level, emotional level of the child, in addition to like the rules themselves. Is a child going to be able to remember? Is a child going to be able to remember what happened to them? Does a child have the patience to wait? How well developed is the child's problem solving skills? So these are things that we need to consider in terms of the kid's cognitive level and the what was going on with the rules themselves. Support the parent to support the child. Assume the child's trying to do their best, and assume the parent's trying to do their best. Parents are people, they're not perfect. Sometimes they are the one who did wrong, but assume that they were trying to do the best. And also, it's important for us to be mindful of our own biases. So, the parent might come there and say, my kid's out of control. And they're blamed, frustrated, embarrassed, guilty, angry. But it's important for you as the doctor to resist the urge to say, well, you're the one who's out of control. I mean, you're not going to hit that unprofessionally, but to kind of then blame the parent out loud. Because that's just not going to help, and they're going to shut down, be more defensive. Well, I think it's always important to consider attachment. In order to thrive, all kids need the caregivers to be responsive. They need attention and affection, clear and appropriate expectations and structure, consequences, regardless of whether they are positive or negative, need to be, it's important for them to be immediate, specific to the behavior so that it's appropriate and they understand it, and consistent. Immediate response to behavior allows the parent to have the most control and will deter or incentivize the behavior that's happening. And so they are addressing a problem or rewarding the good behavior. Consequences also need to be specific to the behavior. The type of reward or punishment needs to relate to the behavior, not based on other things that weren't really related here. And because you're mad at the kid about something that happened last night, or the parent is mad at the kid about something last night. And consequences, like I said, they have to be consistent so that they're not like, okay, today I'm going to punish and tomorrow I'm not. It's not that the parents is necessarily doing that. We all are going to have trouble being consistent. But a lot of times the parent may have an expectation, but as soon as they take the kid out in public, well, they're going to be embarrassed if the kid acts up. So they're not going to respond because they don't want to risk escalating, or they're going to ignore the problem, something in public that at home they would have said don't do, and that gives the kid a confusing message. It's always better to be proactive and reactive. That way you are being consistent and making the punishment fit the crime and all of that. Planning ahead and anticipating misbehaviors might actually help the parents to be more in control. And going along with that, what we mean by emotions being a give and take, and so emotions are also give and take, and parents and child are feeding off each other's emotions. How the parent treats the child can affect how the child is going to treat the parent, and vice versa, especially when all upset. And it's important for the parent to be aware how their own emotions are being affected when the child is getting upset. So it's good for the parent to have healthy boundaries, healthy ways to express emotion, healthy responses when they get upset, because the kid is just watching them and learning how to react to things based in part on what the parent is doing. So positive parenting techniques, I mentioned that before, also important to consider. You address the behavioral issues sooner rather than later. That's what I was talking about, the consequences being right away. I didn't realize. Actually, this, I guess, is more related to this slide. Sorry about that. You establish the structured environments, predictable routines, visual schedules, calendars, verbal reminders. All these can help depending on the kid. Think about what a kid does best with house rules, behavioral expectations. And when parents are putting together rules, it's important to state them positively, not like, don't do this, don't do that, like do something constructive. It's hard to think of one off the top of my head, but let's see. Instead of do not hit your brother, treat your brother nicely. Treat your brother how you want him to treat you, something like that. Like I said, it's important to give that immediate attention and specific praise. So you catch them doing good, the parent does. And as soon as they see it, they just say, that is great. That specific action that you said thank you, that you held the door for your brother, that you said something nice to your brother or sister. And it's good, this is recommended in parent-child interaction therapy, to plan for at least 5 to 15 minutes a day of child-led conversation or play. So that way you're developing a relationship with them, and that relationship is important. The parents are developing a relationship with the child, and that relationship is important. The child wants to maintain that positive relationship and is going to work harder to behave well, so that the parent will, will feel so positively about them. It's important for the parent to learn to anticipate what might happen in different settings or situations, so they can help the kid through it, or help the kid beforehand, pair, give choices, not too many, consider the age of the kid. So, instead of saying it's time to go now, or, we got to get dressed, you can say, you want to wear the red, the parent can say, you want to wear the red shirt or the blue shirt? And not which of these shirts in your drawer do you want to, but, so something that's specific, but it's still it's giving them choices. It's not like you must get dressed. Use planned ignoring, the parent needs to ignore things that aren't that big a deal. Choose your battles. Where can they compromise? Where can they complete a task together? I've argued with parents about that sometimes, like, your kid is beating up the little brother. Maybe it's okay if they make a mess with, when in a restricted area when they're doing arts and crafts, instead of going after their brother, and then they can work on cleaning that up. Maybe it's okay that they get dirty outside for a few minutes and get some more activity. Problem solving with the child. Model that emotion regulation so the child learns. Support through tough feelings. Help the child to regulate, listen to the child, empathize, validate, breathe together, do coping strategies together, so that the parent is like, listen, I'm struggling too. That's okay. It's okay that we're both struggling, and how are we both going to get through it? It can be helpful to talk with the parents about how to give the best command or effective commands. Consider the age or development. Word it positively, like I said before. Communicate, give a statement, not a question. Except for things like, which shirt do you want to wear, that kind of thing. Short, simple, to the point. Make sure that the parent is paying attention to you. There are many times when the parent wants to tell the kids to do something, and the kids on the, doing the video game, and they're remembering. Or notice that it was even said. And communicate this time limit in which the child has to complete the task. So, for example, you might say, if the parent might say, you can play video games for 30 minutes after you clean your room. So that starts with the positive. That's a positive command. Instead of saying, after you clean your room, after you have to do this, you can have the reward. Hey, you can have this great reward after you do the other thing. The thing I need you to do. So punishment. The American Academy of Pediatrics recommends parents do not spank, hit, slap, threaten, insult, humiliate, or shame to discipline their children. Physical punishment is never recommended. And there's a lot of data against physical punishment, showing that physical punishment is not great. It elevates the stress hormones, leads to changes in the brain's architecture. The only positive you get is like a short-term behavior change. The compliance with that does not last. Harsh verbal abuse also linked to mental health problems once they hit preteens and adolescents. But I do think it's important to understand families may have different concepts of how to teach the kid. We can refuse to condone a strategy, but still try to understand it. Like, so this is how our culture does it, and try to figure out how to make it as safe as possible, reduce risk. We can call our protective services if need be, but we also want to be mindful, again, of any bias we might have, what they're talking about, and how any bias might affect our judgment and then our plan of action. So instead of starting off our conversation with the doctor with hitting is wrong, you can't do it, that doesn't help the parent to feel supportive, and then they might just not tell you what they're hitting. Instead, listen, like, what do you do, and learn from that, and then go, well, okay, here's what the research shows. So be straightforward, kind, and acknowledge that the parent is trying their best and trying to fix the situation. Behavior ABCs, that's important. It works a lot in mental health related situations just in general. And so for tantrums and explosive behavior, this is something to consider. The A is the antecedent, it's over here. B, behavior, C, consequence. ABC is also used to mean affect behavior and cognition. That's also important. That's not what I'm talking about right now. I'm talking about first is what happened before, what behavior does it lead to, and what's the result for the child, for the family, all of that. So, and the consequence could be what's causing the behavior to keep happening. It could even be that the antecedent itself is that there is no real antecedent, or the antecedent is not the concern. It's more the consequence is something that's reinforcing. So, one of mine that did not go through entirely, work entirely, so I can find that one now. So behaviors, like I said, can have a function. And like I was saying with that, they can help the kid remove something they don't want to do or avoid something they don't want to do. Tantruming and they're not doing the chore that they don't want to do. It can get attention and on the phone or something else. You get a desired activity or object, give candy from stop. And especially with some of these kids like with autism, it can help them to get more sensory input. Maybe they like feeling like the pressure when they hit, or it can remove sensory input. The parent can then remove them from the teacher can remove them from the situation in order to try to punish them, but that can then remove this sound that they didn't like hearing, whatever it was. Now they're hard to place. This is a chart that parents can use, that you can give to a parent with the ABCs, antecedent behavior. So this is a date and time, the antecedent behavior, consequence. Now we're making the chart myself. I'd probably make the date a little smaller so you get more space for the other three. So parent can fill that out, and then you can review that with them and try to figure out what we need to change along that chart to try to optimize things for everyone. Behavior at school is obviously an issue you hear about. Functional behavioral assessments, or FBAs, are something that are supposed to be done by the school. It can be done as part of like an IEP, is like part of special education, or it can be done part of some sort of assessment. It is required when a child is getting in trouble at school and it's determined that that's because of the child's disability, that the child has an IEP, special education, because of X, and X is what's causing them to get into trouble. Therefore, our plan isn't working. We need to adjust it. So let's see what's causing this behavior. We can do functional behavior. School can do functional behavioral assessment if the ARD committee determines as needed. That's assess review. I'm sorry, I forget what ARD is right now. Discontinue. I don't remember. If the child is being placed in a temporary alternative educational setting for behavior that was really harsh, that we could do it. Texas law requires reviewing or seeking functional behavioral assessments within 10 school days of any disciplinary action that makes them sent to like a alternative placement in a program. And it can be considered in a lot of situations when the behavior is getting dangerous or interfering with learning or progress, or when restraint is required, certainly. These are all things where I would recommend it. Honestly, I'd probably recommend a lot of functional behavior assessments. It's hard funding wise mainly, but a lot of times I'm finding that it's not getting done as much as it probably should be. So after they do this assessment, then you do a plan, right? So you have behavior intervention plan. First, they review the result, and they figure out what was the function, and multiple functions for that behavior. And it's good to continue to assess. Behavior and functions can change. That's important for the schools to be aware of, that they don't necessarily do that. They can consider what might be contributing to this behavior, like academic difficulties, trouble regulating, social skills, medical factors, including lack of sleep. Some of these things the school can deal with, others maybe you need to deal with, like a lack of sleep, referral, having seizures or something. It's important to consider the changes to antecedents and consequences, and to consider replacement behaviors. So a replacement behavior would be something that the child would be able actually to do. So like the kid can't talk, they don't have to ask to do something, because then they do that. And it should be easier than the current behavior. And I think this gets hard because a lot of times the reason this misbehavior is being done is probably because it's so easy. It's really hard to find an easier replacement behavior. But the experts, they should be able to come up with something. It's just, again, that might be where the things stall out at school. But here are some resources that you can get if you get a copy of my slides and find sharing those. So these are some really good resources for pediatricians and for the parents. Here's some programs I mentioned. Okay, medications. I figured a lot of pediatricians would want to know, because that's what they call CPAN about. So if you do feel like you really need a medication, you tried all these other things, parents are really great at working on behavior with the kid and on coming up with alternatives and figuring out what the problem was and dealing with it. So, okay, what are you treating? There's no FDA-approved medication for temper tantrums or angry outbursts. It doesn't exist, so that's something to keep in mind. So think about what's the diagnosis, and that is indirectly leading to outbursts, and treat that. If it's physical discomfort, that's pretty obvious. If they're constipated, treat the constipation. Like fiber, change in diet, medicine if you need it, that sort of thing. So remember that the behavior is a symptom, but temper tantrum is a way of communicating this problem. And then, what about developmental delay? Irritability associated with autism, that's the closest we get to a medication being approved for temper tantrums. There are 2 FDA-approved medications for agitation associated with autism: aripiprazole and risperidone. So usually I start with one of those. If there's some problem with the first one, I go the other one. While not FDA approved, a lot of second-generation antipsychotics can also be useful for developmental and intellectual disorders. So if one doesn't work, you try another antipsychotic. Usually that's what I do. And usually I had written more about like what you could. So anyway, sorry, more on that. And I'm just seeing if there's something I left out. Okay. Then, if the child is diagnosed with some kind of disruptive impulse control or conduct disorder, a lot of times they also have ADHD. So first, you optimize the medication for ADHD, mainly stimulants. Methylphenidate has been found to improve emotional impulsivity and self-regulation in about half of the kids with ADHD. So I usually like methylphenidate. The younger kids, I definitely like methylphenidate. Alpha agonists have been found to be less effective, but to have less side effects than the stimulants. Oh, I'm sorry, the sound is so bad. I'll try. I don't know if I can fix it. Guanfacine extended release. has been found to improve oppositional behavior, and it can be given weight-based. A lot of times people will stop at 4, but if they're a bigger kid, a lot of these kids could get more. But if it's having side effects, stop, or they seem to be doing fine at a lower dose, but I wouldn't increase, just to increase. Clonidine is found to decrease aggression when added to methylphenidate. And sometimes I'll try atomoxetine, or now there's viloxazine, Quellbreak. Atomoxetine has a small effect and can have some of the side effects of SSRIs and some of the stimulants. So it's not really usually up there as one of the first line. I just like letting people know about that. That is another option, especially if you think they have ADHD and they have some sort of mood, like depression too. If the child is diagnosed with a disruptive impulse control or conduct disorder, like I said, you consider, is there also depression or anxiety? And that might be another reason to try atomoxetine, because there's some overlap. You can try an SSRI. Citalopram in particular has been found helpful for behavioral problems that are associated with depression or anxiety. You dose the lowest if it's for depression, a little higher if you think it's anxiety, and a highest if you think they have obsessive compulsive disorders. You follow up for suicidal ideation and activation. The most common side effects, though, are stomach aches and headaches, changes in poop, like either constipation or diarrhea, either one. For bipolar disorder, valproic acid has been found to help with oppositional defiant disorder and conduct disorder that is associated with mood lability in ages 10 to 18. It helps when the stimulants are inadequate. High doses will help more than low, so like 500 to 1500 milligrams per day. But I avoid it in women, in girls, like across the board. I always try to, because eventually, if that's what's working and the girl is on and taking it, it is known to cause birth defects. Whereas other things, the risk is other medications can help, and do not necessarily cause birth defects. So usually, if it's a girl, I don't even consider valproic acid. Risperidone has the most data for bipolar disorder with the behavioral problems. You use half a milligram at bedtime and increase by half every 3 to 5 days, with the goal of getting to 3 to 6. Quetiapine has some data too. You can use 25 twice a day and increase by that amount every 3 to 5 days, trying to get up to 50 to 600 milligrams per day total. Aripiprazole takes longer to dose and you to work, but you might need a lower dose, which could be good. There's some evidence for haloperidol, about 3 milligrams 3 times a day. Out of all the first generation antipsychotics, not great. Lithium, 600 milligrams 3 times a day, also not great, and actually has fewer side effects than Haldol. Haloperidol is the generic name. If you're giving a second generation antipsychotic, you need to start with the fasting labs. I've been burned too many times where the parents say, oh, yeah, I'll get them, and then they never get around to it. You try it at whatever starting dose for about 4 weeks before you adjust. Oh, sorry, not starting dose, sorry. Once you get to this therapeutic range, I misspoke. Once you get within that range, you hold it for 4 weeks before you adjust. And then if they're still not responding, there's some data for adding in, because like I said, probably start with antipsychotic, for adding in lithium, valproax, or clonidine, which is not nearly as many side effects for oppositional defiance disorder and conduct disorder. For antipsychotics, I said check the fasting lipids, CMP, CBC with differential, TSH, free T4, urine drug screen, and urine pregnancy if they're old enough. You also keep checking for movement disorders. Ask if there's any stiffness, any movements they can't control. Don't pre-medicate for any movement disorders. Don't give Visceral to start with, because that can hide like tardive dyskinesia, and then it can last long enough to become harder to reverse. Often it's irreversible. Lithium, you need to check the kidney function, thyroid, and lithium levels, and the kidney and thyroid is before you start to valproic acid. Again, liver function tests, and that you check before and after. SSRI, there's no specific labs that you would need to check, but you monitor it. Oh, what happened? Okay, someone else is in control. I don't know what happened. Okay, and I don't know how I took it back. Okay, whatever. So you again monitor any SSRIs. If you're giving fluoxetine, you monitor it for 10 to 20. Once you get to 10 to 20, you monitor it for 4 weeks before any further adjustment. Maximum is 60. No response to an SSRI within 6 to 12 weeks, and you taper and you try a non-SSRI. Sometimes people do phenytoin, 100 three times a day, 200. That's for adult, really, an explosive disorder. And some people try oxcarbazepine, has fewer side effects. Carbazepine has more. Oxcarbazepine can be 150 or 300 to start, increasing to 150 to 300 every 2 to 4 days. Goal of 1,200 to 400. And you give that one twice a day. There isn't much good data on that. Try that. If the co-occurring conditions are adequately treated, it's been found to help treating oppositional defiant disorder or conduct disorder with risperidone or other antipsychotics. If intermittent explosive disorder is and any other co-occurring disorders are adequately treated, then SSRIs, that's your first line, because it's largely mood and anger. Fluoxetine is recommended in adults. There's a lack of data in kids, but I usually go with an SSRI if I think it's intermittent explosive disorder and not something in addition to that. If the child is diagnosed with a mood disorder as their primary diagnosis, opposed to associated with a behavioral disruptive or behavioral disorder, you can, there we go. You consider is it irritability associated with depression? Again, SSRIs, they're generally first line with disruptive mood dysregulation. Nothing's FDA approved, but it is considered a form of depression. I generally go with SSRIs. Bipolar disorder, again, I generally go with second generation antipsychotics. You can use PRNs for agitation, like diphenhydramine, hydroxyzine. I don't usually go with benzos. I'm not a fan of that. Diphenhydramine, Benadryl, you give 25 to 50 milligrams 2 to 3 times a day as needed. Hydroxyzine is 12.5, 25 milligrams every 6 hours, 4 times a day as needed. Lorazepam, if you need it, is a quarter to 2 milligrams, maximum 4 per day. And you give that every 6 hours. Like I said before, antipsychotics have a high risk of side effects. Lorazepam seems to have the lowest proportion of side effects. So if you want to try, you could try that. Oh, I see, it's not right. Oh, there we go. Sorry. Hand misuse disorder with mood symptoms. Gabapentin has been found to be helpful. You can try that. That's not much data yet. If they have PTSD, and you can do alpha agonists. So some of the support. Guanfacine is good for behavior. Prazosin's found to help with PTSD, but guanfacine's found to help with behavior more specifically. You can start at 1, increase by 1 milligram each week until it's effective. The maximum is considered 0.08 milligrams per kilogram per day total. Prazosin can help with sleep, 1 milligram 30 minutes before bed, at least 5 milligrams, though I usually don't actually get up to 5 milligrams. So theoretically, because you need to get to at least 5 milligrams, but again, I don't have any kids that high. And you get there over 4 to 8 weeks. The side effects of the antidepressants themselves can be irritability or behavioral outbursts, so that's something to consider. But usually you start with SSRIs, NRIs, and tricyclics could be second line. Guanfacine has been well tolerated for post-traumatic stress disorder, and like I said, and it's been found to be helpful in anxiety. There's a lack of evidence for buspirone in children, but it also lacks adverse effects, and so sometimes I will use it. Main issue is it's 2 to 3 times a day, and people have trouble sticking to that. Benzos can work very quickly, but they lack data and they have some major side effects, and they can make you more irritable, positional in a kid at least. And the kids can develop tolerance and addiction. Here are my references. Here's a CPAN social media. Okay, and I know someone asked specifically about using CBD for mood. I just wanted to make sure I answered in the chat real quick because I was trying to also talk. So CBD can, at least certainly over the long run, make mood worse. When I've reviewed research, what seems to consistently to be the case is CBD helps with like seizures, like intractable seizures, like it can help with muscle issues, muscle spasms, and it can help with someone can help with nausea, but can also make nausea worse. You can get this intractable vomiting from it. So you have to be really careful with it. And people look at it as a cure-all. I think it mentioned in my intro that I'm now in Florida. In Florida, CBD is legal medically. It's legal just recreationally. I don't see patients here, so I don't know exactly what's going on in terms of as a doctor, but it doesn't. It concerns me because kids see it as, well, it's legal, well, it's for fun, well, it helps with anxiety or it helps with mood, but it helps usually in the short run and then can make you feel a lot worse because you kind of get dependent on it. I have had some patients who are using CBD kind of under the table, I guess, for autism, who seem to do much better. And I think some of these kids where they're really not functioning well at all, and they take the CBD, so now they're not like hurting themselves or attacking other people when the antipsychotics didn't work, then that's something, and that's not necessarily something to be dismissed. I don't know that what the research has said about that per se, but I have found some benefit there. But yeah, no, I don't like it for mood or anxiety, certainly, because it does, you do get addiction and withdrawal and everything like that. Any other questions? Sorry, talked too long.
Yes, I want to go ahead and open it up, definitely, Dr. Lobel. Open it up to those who are still in attendance here. What kind of questions do you have for Dr. Lobel? You can either put them in the chat, or you can certainly unmute yourself and ask your question. And we have added the QR code for Cloud CME. That is for physicians as well as physician assistants. As nurse practitioners, you can certainly use that, or we can also provide you the NCPD credit as well, that information. So opening it up, what kind of questions do you have? This is a topic we at CPAN hear a lot about, all different ages.
I have a question. I had a 16-year-old that came in, and so he was a little bit of like conduct. He didn't really meet like the full criteria. But when I was talking to him about like depression and his mood, he denied all of that. The only thing he really said was like he gets anxious here and there. And I started him on the Abilify just because his concern was like the weight, when I was talking to him. Should I move him to something else, or I mean,
is it helping him with the Abilify?
I'll see him this week, actually.
Okay. So you said mainly he's noticing anxiety.
Yes.
You could try like an SSRI, especially if the Abilify is not helping. The weight gain can happen with Abilify.
Okay.
At that age, and you can have it. I've seen it in adults too, but in kids and teens, you definitely still get that weight gain with pretty much any antipsychotic, unfortunately.
Okay. Yeah, because he came in with the Intuitive for ADHD, and him and Dad said that was helping a lot. But
okay,
the behavior,
but not the tantrums.
Mm-hmm.
Yeah. So sometimes I'll try Stratera too, because if you said more anxiety. Because Stratera was originally designed to be an antidepressant that essentially didn't work out as an antidepressant.
Oh,
and
wow.
Somewhere along the way, they found out that it works for ADHD. And then they kind of backtracked and figured out that if you have ADHD and depression, I think I've seen some research where it does seem to help a bit with the depression. I have tried for anxiety because at least in theory, I would think it might help. I don't know if it's helped or it's just a placebo, but sometimes if they have ADHD, but a big part of it seems, or they also seem to have major mood or anxiety, something I'll try Stratera.
Okay. And then you said also try maybe like an SSRI, right?
Yeah, or you could try an SSRI.
Okay. All right. Thank you so much for that.
Sure.
Great question, Jacqueline. All right. Other questions? We still have a little bit of time here. So let me ask a question then, Dr. LaBelle. How much of dealing with the temper tantrums and explosive anger needs to be treated by therapy versus medication? And then what do you recommend?
Usually I recommend that people do behavioral therapy or work on parenting techniques. A lot of times we can try to find someone who will work not just with the kid, but with you too, because a number of the therapists will try to work just with the small, like with the teenager, it's one thing, with the small child. And the problem is that they're having tantrums. So the parent and other people who work with it, who see the kid on a daily basis, need to be able to reinforce whatever so that the kid's not having so many tantrums. So a lot of times I'm talking to the parents about what they can do differently and trying to refer them to someone who will work with them more on that. Because that is that's the main thing to do, and that's something that you can keep doing even if you lose your insurance, if you lose your, if you can't afford the medicine, you can still try to parent differently. Plus that's better data on it.
That's great. And that is something that we at CPAN can assist with as well, is, not only that curbside consult between a primary care provider, be it a physician, a nurse practitioner, or a PA, but also assisting in locating and vetting those resources. So you really have the ability to have that expert advice from a psychiatrist if medication is needed, but you can also get those vetted resources from CPAN to go along with those if that's appropriate. So thank you very much. I appreciate it, Dr. LaBelle. Any other questions from our group today? No other questions. All right. Then I will go ahead and end today's session. I did want to let you know our next session is scheduled for the 28th of August. That session is recognizing and treating eating disorders in primary care. And so we certainly want to invite you and encourage you to join us. Again, that is a Monday. It is from noon to 1 p.m., recognizing and treating eating disorders in primary care. Our fall Echo series will be starting back up again in September. You should have seen, if you joined prior to our session beginning, you should have seen more information about that on our CME slide. If you have any questions, please reach back out to us at CPAN. You can reach any of the hubs by 888-901-2726.